All right, for this topic, we'll begin looking at hemodynamics. We're going to spend a little bit of time just talking about vital signs, which I know you're all familiar with. And then we will talk about the more critical monitoring. So we'll specifically talk about art lines, CVPs, so central venous pressures, and pulmonary artery catheters. They're pretty straightforward, and I will be honest, the only reason that I'm really including these is part of your NCLEX blueprint. National Council of State Boards of Nursing, you're seeing more and more information about lines, tubes, and drains, safety and infectious control. So you can find information about these lines, tubes, and drains. But when you do see those questions, I want you to think about, okay, this is probably wanting me to be a safe nurse, because these are specialized opportunities. They're in the ICU mostly. Can't say that across the country you're not going to find an art line, on a random step down if it's a little more high speed. But what we're going to do is kind of pick the big pieces, the stuff that we are going to find important to managing the care of a client with one of these methods of measuring their vital signs, blood pressures, heart rates. All right, so the easy stuff first. We know that we have invasive and non-invasive measurements of pressure, flow, oxygenation. Right? We know that we can obtain a set of vital signs. We can look at the map. We can get an SpO2. I can get a respiratory rate, all the good stuff that we would use to make critical decisions about our plan of care. We do this because we want early detection. We want early identification and treatment plans for those potential or real life-threatening conditions. These tools do allow us to evaluate the immediate response to treatment, especially medications and mechanical support. If you're looking at a map through an art line and you're titrating a medication, you're going to see almost instantaneous changes. And that's why we have those orders to titrate X medication to maintain a map greater than, and again, depending on how sick the client is, 60, 65, somewhere around there. Sometimes you may see 70. And then we want to make sure that I'm looking at each piece of that information to evaluate that effectiveness. So we can look at things like stroke volume and cardiac output and cardiac index to make better determinations of things like preload and afterload and mean arterial pressures. So basic hemodynamic monitoring can be done anywhere, right? We know that vital signs are key indicators for our assessments, especially if we have any suspicions of shock. Shock, sepsis, MODS, multi-organ dysfunction syndrome, SIRS for systemic inflammatory response syndrome. We need to look at this information to be ahead of that disease process. So, in medicine, we need to be a couple of steps ahead of whatever is going to happen next based upon that client's signs and symptoms. So that's the easy stuff we'll talk about. And then we also understand that most invasive hemodynamic monitoring will happen in our ICU settings. So those of you going to work in the ICU, you'll become more familiar with this information. So we have our blood pressure monitoring, our manual and or our digital. Make sure, again, my little tirade about making sure the blood pressure cuff is the right size, that it's in the right location, that you have the line lined up to an actual artery, that if you get an abnormal number, that you're retaking a manual blood pressure, or that you're using at least 2 arms if you are getting weird numbers. Right? There are lots of things that can happen internally that we can't see as a nurse that could affect my evaluation of that client's blood pressure. And a big one is going to be AFib. You can, if you see that AFib animation that I had in the PowerPoint or the video, you see that how that heart rate kind of jumps up and down. And we know blood pressure is equal to cardiac output times systemic vascular resistance. And one of the things that makes up our cardiac output is heart rate. So heart rate and stroke volume. Pulse oximetry, it's either continuous, it's intermittent. Make sure that you have an order to titrate if needed. Make sure that you have them on the correct amount of oxygen and on the correct oxygen delivery device. That we want these clients, because this is a cardiac test or a cardiac client, that they're going to be on continuous monitoring. So we're either going to be doing 12 lead ECGs, so for that new recurrent kind of chest pain, if we have changes in rhythm, changes in heart rate, and they become symptomatic, you can perform a 12 lead. Again, we'll be looking for things that help us identify where that area in the heart that the issues are. But probably more common is that we're going to have all of these clients on continuous telemetry. That's going to allow us to assess for any kind of ectopy or changes. It's going to allow us to see any new or acute issues with ST depression, ST elevation, T-wave inversion, which could be indicative of our ischemia or injury. We can use capnography. That will not be on the cardiac test. Hopefully you learned a little bit about that in the respiratory unit. But that's going to be typically for somebody who has issues with exhaling CO2, and especially if we have them on a PCA pump and it's a medication that could potentially depress their drive to breathe. Invasive monitoring, we're going to talk generally about art lines, CVPs, and PA catheters. So art lines are pretty straightforward. Generally speaking, it's going to be somewhere in the radiobrachial-femoral artery. It is a direct line into that artery, which means that you have huge issues for increased risk for infection, for embolus, thrombus. Make sure that if you do have a client with an art line, that we are using the numbers to evaluate what we're doing, that we're making changes to any medications or to any settings based upon what we see. But more importantly, please make sure that you do not give any medication through an art line. I know that normal saline or heparinized saline, although I have not seen that used in forever. I know what we will use normal saline, and technically that is a medication. But that's about it as far as medications that I would want to see go through a art line. CVPs is more of a right-sided thing, so we're going to have a catheter in the right atrium, and it's going to give me the central venous pressure, which is just a fancy way of saying that I'm going to be able to measure or look at or evaluate my preload. And then pretty much the same for our pulmonary artery catheters. They're going to help us maintain a good cardiac output. They're going to give us information about wet or dry, and then just help that heart out. It's going to give it a little extra oomph. Again, from my perspective, since this is still supposed to be basic nursing, right, on NCLEX, the big issue is going to be from a safety and infectious control type of area. It's probably one of two things. Hey, do you understand how to evaluate what you're doing with an art line? Do you understand that a CVP or a PA pressure can represent fluid volume? But anytime we're inserting a line, you have a huge risk for infection. Safety and infectious control is going to be a huge part of your NCLEX. So here we kind of see an art line set up. So this is the forearm, the hand is over here. You see the catheter in the radial artery. You see our pressurized, now this has the heparinized saline. We have a pressure bag. We use a pressure bag because if we didn't, your arterial system is under a high pressure. So notice that that pressure is significantly higher than my 120/80. So if you do have a client that does have issues with hypertension, you can see why we would need a very high amount of pressure to keep that kind of blood in the vascular system instead of leaking out into your tubing. Mostly we're going to make determinants based upon the map. You will see your clients that will have an art line. They will have a display for their arterial blood pressure as well as their electronic blood pressure, the digital blood pressure. You can draw blood from this, so ABG sampling is allowed. But again, just be careful. Again, it's a huge risk for infection. Radial, femoral, probably more prevalent just in my practice. But, you know, if we can't find anything there, we can certainly go to the brachial artery. So we do have some relative contraindications. So any kind of decrease in circulation. So this is, again, why we perform that Allen's test to make sure that I still have some perfusion till that distal digits. Active infection / sepsis, trauma, especially if we don't understand what's really happening inside the body. If they have any kind of excessive anticoagulation, so they come in, we get labs, and the PTT or the INR are really high. Complications are huge. Hemorrhage, emboli, and then of course we've talked about never administer medications through the art line. And then we can see here that this person unfortunately had a medication that was administered through the art line and it infiltrated. And since most medications that we give are battery acid, as far as continuous or IV piggybacks, you can see that we caused a lot of damage to that person's arm. Not we, this is from Google. So again, here just kind of the setup, what we see. You see the waveforms on the monitor. They're going to line up with what your PQRST kind of look like. You see the pressure bag. You see the transducers. You're going to have to do some leveling out once you're in one of those high-speed critical errors. I'm not going to talk a whole lot about it, but it requires the nurse to do things to make sure that we are getting accurate readings. Okay, so pre-insertion, just look at the Allen's test. Make sure we have collateral circulation. Post-insertion, you'll make sure that you're assessing that site, that you're securing that catheter. Again, if this catheter comes out, it's a huge risk for bleeding or hematoma. Again, when you get into your critical care courses, you will ensure your waveform accuracy so they will be relatively close to each other. You're going to assess for complications. It's the normal complications: thrombus, infection, spasming, which can really throw things off. Maintain proper zeroing of the calibration of the transducer, which is just a fancy way of me saying when you had to do something for that client to get an accurate reading, that's what it is. You're going to use your pressure bags to prevent backflow. And then we want to teach them, just like we do when it's in the AC, they want to avoid generally bending the wrist because you've already got a catheter there, and it just increases your risk for bad things happening. And here's kind of that picture that I told you I would show you as far as our numbers are concerned. And I'll read the CV portion of it. So if I come down here, this is the first thing I notice. I do have an arterial blood pressure. It's 106/63. And that map is 79. So you can see down here, I do have the digital, so the blood pressure cuff. NIBP, right? Non-invasive blood pressure. And you can see that it is very different. So that's why we would use the ART line for the accuracy of being able to titrate a medication to whatever their MAP is. Now this person's MAP here is 79, and that's fantastic. So if I had them on a drip, right, I wouldn't have to do anything. In fact, what I would probably see is I would have to decrease the medication because you want to set it to very specific parameters. So sometimes you'll see, oh, greater than 60 or greater than 65. Other times you may see a range. Keep the client's MAP between 60 and 70. The other piece of this information that we have is this central venous pressure. Now, none of this relates to my central venous pressure. It's basically that catheter. We said it's going to be inserted into the right atrium, and it's going to tell me about preload. So that's volume. So I get information about the volume and the stretch of the ventricles. We're going to use the numbers 2 and 6. Anything 2 or less means that the client is probably dry vascularly, because that's what the measurement that we're taking right off the superior and inferior vena cava to the right atrium. Anything greater than 6 equals wet. Basically, it's just the opposite of thinking about a BUN and what information a BUN gets me. Low is dry, high is wet. We'll use that for CVP, and we'll use that for our pulmonary artery pressures. Our goal is to maximize homeostasis. So what I want to think about here is I have a client, I'm in the ICU, I'm giving a ton of fluid. If I'm giving you a ton of fluid and your CVP is still 2, so you're 6 hours in, you're 10 hours in, 12 hours in, whatever it may be, and that number is not coming up, you have to ask yourself, where is that fluid going? And what's probably happening is that you are starting to see either the development of pulmonary edema or peripheral edema, third spacing, ascites, however it's going to manifest, because that fluid, instead of participating in the circulatory process, is leaking into your interstitial spaces. So we would have to address that immediately. What I do see, and the next thing we'll kind of look at after CVP, is this pulmonary artery wedge pressure. You see how much lower that is than what we would expect for a blood pressure, and that's because it's the right side of the heart, the pulmonary artery wedge pressure. So remember, the pulmonary artery is right there off of the right ventricle. So again, central venous pressures, we're going to use 2 to 6. Greater than 6 is wet. I'm not trying to trick you. I'm not going to say, oh, it's 7, because I know that some books say that a normal CVP is between 2 and 8. So if I want you to understand that that client is wet and the question is about a CVP, then the number is going to be noticeable. So if I give you 12, if I give you 15 for their CVP, that you know that you need to assess for edema, listen for crackles, check for ascites. Unfortunately, this can be caused by aortic stenosis, because what's going to happen is that stenosis is going to prevent that volume from participating in that perfusion process, and that volume of blood is just going to back up, and that's where we start to see it in the lungs, and then once it passes through the lungs into systemic circulation. Dry is anything less than 2, especially in the presence of continuous fluids or bolus of fluids. So kind of here again is what we are talking about when we say it is a representation of being a pump or a volume. CVPs and PAWPs are typically talking about preload. So we see the CVP, we see the pulmonary artery wedge pressure. And then, of course, we see the assessments that we would associate with either lots of fluid or not a lot amount of fluid. That's why we know that I can't look at somebody's preload, but I do get information about their preload from just doing an assessment. So you ask yourself, why would these increase or decrease? What are we doing to this client to either have their number low or have their number high? Have I hit them with 80 milligrams of furosemide for 4 days in a row and not giving them any fluids? Are they on a fluid restriction? Do they have a poor ejection fraction? So lots of stuff that we could be thinking about. So the pulmonary artery wedge pressure, so you will see it either as a pulmonary artery pressure, pulmonary artery catheter, pulmonary artery wedge pressure, helps us look at left ventricular end diastolic pressure, right? Again, it's just talking about preload. It's a lot of fancy words to say, I'm looking at preload, and by assessing preload, I can make determinations about things that I need to do. We have great ways of measuring afterload because that's our blood pressure. That's our art line, that's our manuals, our digitals, whatever it may be. So these will give us more information. The normal value for this is 6 to 12. And that's nice because I just do 2 to 6. And then 6 to 12, because both of these things mean the same. All you have to ask yourself is the question asking me about this, or is it asking me about a CVP? So, to help you just kind of remember it, and I know it's backwards on the screen, but the 2 to 6 is basically information about that right atrium. 6 to 12 is information about that left atrium, right? Both things talk about the volume of blood in the left or right atrium. They both, again, just mean wet or dry. If I have, like hypovolemia, dehydration, hemorrhage, those things are kind of easy to figure out when you have a low number for the pulmonary wedge pressure. If we're talking about greater than 12, so wet, fluid overload, it's probably related to a left-sided heart failure. You can have issues with volume returning to the left side of the heart, so issues with shock or maybe mitral valve disease, aortic stenosis, things like that. Sorry, it took forever. All right. For pulmonary artery wedge pressures, they're going to inflate this balloon. It's only going to be inflated briefly to avoid rupturing the balloon, so that it's going to be very specific on the policies and procedures for using this. And again, that's too deep for us, but you should know that if somebody asks you, oh, why is my dad getting a pulmonary artery wedge catheter? It's to give us more accurate information about their ability to maintain homeostasis, to perfuse, to help the client recover. This reading will be obtained at the end of expiration for accuracy, because if I'm inhaling, I have a greater thoracic pressure than when I exhale. So we want it to be about the heart and not just about the pressure. Again, you're still going to monitor the client for infection, arrhythmias, pulmonary artery rupture. Again, you're going to have to check the position of the catheter on a chest x-ray. And again, I don't at least I'm not saying they're not still out there, but I don't see these used as much as they were, say, 15, 20 years ago. Just like our CVP, the PAWP has contraindications and complications. Again, this is going to be more related to the actual heart itself. So if you think contraindications, it's endocarditis, it's masses to the right side. So if I had maybe lung cancer or some sort of issue with fluid accumulation, you could certainly think more about whether or not the PAWP is actually needed. They have tricuspid valve disorders, again, because we do have to thread this one, and that's why I put this picture here, through those valves, and because it's going to come back to that left atrium. Complications are pretty much the same. You can have injury occur to your valves. You can end up with an air embolism. You still have this foreign object in your heart, which could lead to arrhythmias. And then there's that big piece, that safety and infectious control again. So our measurements, we see, I did a side-by-side comparison, why we use them, and then, kind of for the more high-speed people that want more and more and more, this kind of just shows you a really cool little illustration about what the pulmonary artery catheter does, and then some of the information that they look at. So that is the end of that lecture. Yay, we kept it under 30 minutes. So we'll go ahead and do a separate one for hypertensive crisis. If you have any questions, please feel free to reach out, bring them to class with you. I'd be happy to answer them.